Hello. Just wanted to touch bases with you guys and be available if you had any questions. You are over halfway done with this course, but I've given you feedback on your sub notes. I'm just gonna talk a little bit about billing, levels of care, ICD-10 codes, and CPT codes, because they really don't teach us this enough um, in school. So I am going to review some things with you. I've heard that some of your preceptors have mentioned some of these things. Let's talk about ICD-10 codes that you all don't like to use. So I'm talking. This is for anybody. Anybody that's into billing, coding, and providers should know about ICD-10 codes. So we're going to talk about what it is, why we use it, the structure of it, why they are important, why you should be specific with your codes, and codes to avoid. Okay, so now you know that now we are on ICD-10, no longer ICD-10-9. It helps with consistency, quality, and that's how you get paid. So it is a structure to it. The more you use it, you'll find the flow of it and the complexity of the code. It helps with accuracy, supports research, enhances communication between providers and standards, keeps us accountable while we are seeing these patients, and it shows the severity of care. There are thousands and thousands and thousands of ICD-10 codes, so we should not be vague and non-specific. Is it important to know if they have right hip pain or left hip pain or bilateral hip pain? It just says hip pain and unspecified. I don't know where the pain is. You should be knowing if you're dealing with the right side or left side, surely, right? Think about a fracture. You got 17,000 codes just for fractures. So think about the timing of the condition. Did it just happen? Was it abrupt? Acute versus chronic. You know, chronic is usually over 6 months. Do they have any other medical conditions? That is so important. So is it hypertension with heart failure? Is it diabetes with kidney disease? Is it low back pain with sciatica? Is it a fever or low fever? Like I said, is it the first time that it occurred? Have they had this problem before? That's why you ask all of those questions for your sub notes. Is it bilateral or unilateral? So think about how would you code an earache, otitis media, otitis externa, hypertension. I just talked about it. Is it benign heart disease with heart failure? I just talked about all of those. So avoid that word unspecified. Try to be specific. Is it left versus right? I just said initial, subsequent. Is it delayed healing, non-healing? All of those things are important for your codes. So you can actually, you know, back in the day we had a big old book so people look up codes. You can actually Google ICD-10 codes. It is good to prioritize your diagnoses. As primary care providers, usually if it's a mental or psych disorder, I usually make that my third or fourth diagnosis. But you do need to prioritize your diagnosis. Should hypertension be first or should diabetes be first for your patient? Electronic medical records, they help. They will provide you with codes. And make sure you support your diagnoses with documentation or review the documentation. Those are some resources for you. Let's talk about CPT codes, levels of care, and practice management. This is how you get paid. So I noticed when you log patients into Meditrek, a lot of you are doing level 1 and 2 visits, which I was told you don't have a level 3 or 4 sometimes visit. So level 1, well, it used to be like a RN visit, just a nurse visit or vital sign check. So if you're, as a nurse practitioner, you really are not dealing level 1 and level 2 visits. And I do my own billing. So I'm going to share this information with my biller, which they already know about it. They'll say this is a level 3, this is a level 4. A level 3 is supposed to have this many codes. A level 4 is supposed to have this many codes. Surely, if a medical biller knows this information, you as a provider should get comfortable with it too. So this is the business that we have, evaluation and management. That is billed by a physician or nurse practitioner. That's a big deal. Right now, we got when people are doing annual wellness visits, and that's a whole other thing. That can be done by RN or LP. That's why I say it's a big deal when you are providing the services and not somebody else. Do new patient versus established. So it's been some changes. So before 2021, we bill based on their history and physical. We no longer have to document all those 12 systems that you all want to document so bad and do a complete physical. That's not needed. But it still must be performed. The way you grade your level of visit, this is good. It's by the level of decision making and the time you spent working with the patient. That's a big deal. This is a good thing for us. It rewards us for our level of thinking and for how much we actually, what time we spent. They don't want you documenting a 3-page soap note anymore. They want to see your level of decision making. Did you have to refer them out? Did you have to do referrals? I just said that. Do I have to go to the hospital? Do you have to talk to the emergency room? Do you have to talk to the pharmacist? All of those things. So levels of care, like I said, you got a level. This is like level 3, 4, and 5. So actually, almost now, level 5 is pretty much, look at that time, 60 minutes or 40 minutes. You're almost having to send them to the hospital or do referral. We usually do this level 4. Yes, they pay different amounts. If you are doing level 1s and 2s in your clinic, you're going to be out of business. You should have at least a level 3 as a provider. So what they use to code and grade your level of visit, that expanded problem focused history. You know how you all don't like to do focus exams? And then expanded problem focused examination. Straightforward medical decision making. That's the number and complexity of problems. Just as I said, do they have diabetes or do they have diabetes with a blood sugar of 400? Do they have diabetes with an A1C of 10? Have they ever had a heart attack and they have diabetes? Are their feet numb and they have diabetes? Those patients are more complex, and you get rewarded and paid more for those patients. Here are the codes. We have prolonged service code. This is a bad copy, but you can look it up. So you hear me talk about levels. Level 1 is not even on here anymore. You got 2, 3, 4, and 5. You can look it up. It's a 2023 E&M coding tool. Like I said, they do not teach us this, but your preceptors will notice if you're able to talk about this in a level of visit. So you know how to reach out to me. You're over halfway done, so let's get it. I'll stop my share and end.